There's no white or black in oncology. There's a lot of gray areas. In the earlier times, it was well known to be a fatal disease. It's been decades now that there's been so much of evolution and innovation and advancement in cancer care. Any form of cancer gets diagnosed at a very early stage, probably help diagnose a breast cancer, a gynae would probably help diagnose a cervical cancer, or an ENT surgeon would help diagnose a head and neck cancer. So in India, medical science and the accessibility to medical treatment is very dependent on your financial situation. And that's unfortunate. That's not how things should work. There is a difference in the government setup and the corporate-private setup in healthcare. Private-public partnership, which means that the government liaises with the private sector and then creates a hospital or a system where people have to pay less in order to afford the same standard of treatment that the private hospital or corporate hospital would offer.
So, first of all, it's an immense pleasure to be having the opportunity to talk to you. And I'm
Thank you.
really excited for this conversation that we are going to have. So,
Thank you. Thank you for having
starting
me.
with it, why did you choose this field?
Um, so, um, so I finished my medical training almost 6 years back. And then when I was preparing for my postgrad entrance exam, I was thinking about what I would ultimately do in terms of specialty training. Um, and then there was a dilemma as to whether I wanted to be a medical doctor or a surgeon and things like that. And there were lots of friends and seniors who had their own ideas and interests, and all of their guidance played a role as well. And then there was a particular a person in my life. She was basically the mother of one of my juniors, Dr. Swarupa Mitra, and she is a very well-renowned radiation oncologist practicing in India. She's based in Delhi. Um, so I met her when I was in my final year internship here, and I didn't know anything about oncology till then because we don't really have oncology as part and parcel of our MBBS training. And so I spoke to her, and she was a very inspiring figure. And I used to look at her social media posts and hear her speak and hear about oncology patients and how she is deeply involved in their lives and things like that. So that got me very interested because I realized that oncology, although we didn't really know a lot about the disease or the treatment options when we were being trained in MBBS, but then talking to her made me realize that it's a very evolving field with lots of intricate relationship that's built between the doctor and the patient. And then it's basically a science of hope at the end of the day, because there's such a lot of innovation, so many treatment options to discuss and to try, treatment outcomes dependent on lots of factors. So there's no white or black in oncology. There's a lot of gray areas that are still, uh, you know, waiting to be cultivated and things like that. So very innovative, very exciting, very challenging at the same time, that kind of thing. And that got me quite interested in the field of oncology, which is why I decided to try how it feels to be an oncologist. And then that's when I took my medical entrance exam, my postgrad entrance exam, and then got into oncology training. And then, yeah, that's how it all started.
Okay, so what exactly is your job currently? Like right now, what is your work on a daily basis?
So I am practicing as a clinical oncologist in the UK now. So I trained in radiation oncology in India. It's the same. Radiation oncology is nothing but clinical oncology. It's just that the nomenclature is different in the United Kingdom in medical science. So we basically treat patients with radiotherapy primarily, but we are also trained to treat patients with systemic anti-cancer treatment, which is chemotherapy and immunotherapy, targeted therapy, and things like that. So we help in the diagnosis. The diagnosis is preliminarily done by core science doctors, so core medical science doctors, which means a surgeon would probably help diagnose a breast cancer, a gynae would probably help diagnose a cervical cancer, or an ENT surgeon would help diagnose a head and neck cancer. And then once they have the biopsy proven cancer as a diagnosis, they are referred to us. And then we formulate the treatment plan as to what options can be tried. We try and personalize treatment on the basis of patient characteristics and because one size doesn't fit all. So that kind of consultation basically happens with the clinical oncologist. And then once the treatment plan is formulated, we help treat patients with radiotherapy, because that's one of the pillars of oncology treatment. And then the systemic anti-cancer treatment, sometimes we do, sometimes the medical oncologists do. So there are two kinds of oncologists, the clinical and the medical oncologists. So medoncs are more well-trained in the chemotherapy, immunotherapy part of things. So anything that goes inside the body via the systemic routes, which is oral or intravenous, and we do the radiotherapy bit.
Okay, great. That sounds very interesting. So do you consider cancer to be a fatal disease?
No, I don't. I mean, in the earlier times, it was well known to be a fatal disease.
Yeah.
But since, I mean, it's been decades now that there's been so much of evolution and innovation and advancement in cancer care that we know now. And I think it's a well-known fact by now. People have been adequately made aware internationally that the earlier it is diagnosed, the better. So if any form of cancer get diagnosed at a very early stage, when it's still very local, it's still locally occupying the organ where it has originated and it has not got the opportunity to spread elsewhere, then it is very treatable, very curable, and very easily curable. In fact, there are some kinds of cancer that are worse as compared to the others. So it also depends a lot on the type of cancer. But if you just ask me a blanket statement and ask me if I feel that cancer is incurable, I would say no, because there's a lot of curable cancers now in the world.
Okay. So, as you mentioned that it's been decades since the stigma was present that, cancer is equal to death. So a lot of advancements in cancer treatments have been made. So do you think that these advanced treatments are actually reaching to the people who need it the most? Or is it just, specific to a particular community who can afford it or who understand it?
Yeah. So in India, I mean, medical science and the accessibility to medical treatment is very dependent on your financial situation. And that's unfortunate. That's not how things should work. But there is a difference in the government setup and the corporate private setup in healthcare. There is now a lot of work going into private public partnership, which means that the government liaises with the private sector and then creates a hospital or a system where people have to pay less in order to afford the same standard of treatment that a private hospital or a corporate hospital would offer. But having said that, we're still not there yet. So it still depends a lot on your financial status, and the advancements that we see in terms of very niche things nowadays, like immunotherapy, targeted therapy, targeting particular molecules and proteins that the cancer cells are positive in order to try and increase survival and things like that, or a very targeted form of radiotherapy that will spare everything around the tumor and very selectively target the area that we want to treat. So that kind of advancement is still not very readily available in all hospitals, I would say. Definitely not in all government hospitals. Very few government hospitals would probably rampantly offer immunotherapy and very expensive drugs that are very recently approved by the FDA and things like that. Which is why, yes, finance does matter. At least in our country, it still does. In countries like the UK, where I'm now practicing, because there's something called the NHS, which is the National Health Service. So it's basically a health protection and free of cost health protection that is offered by the government for all the people living in the UK. You basically pay an amount of money as tax from your salary every month, and that gets accumulated, that goes to the government. And then when you fall ill, then the government then sponsors all kinds of treatment that you may need. And it's all a very good system that they've developed in terms of financially supporting you when you fall ill, because not everyone will have that financial backing to afford all kinds of treatment. So yes, in our country, because we don't have that yet, a lot of treatment still does not reach every section of the population. And it depends a lot on where you belong from or where you are geographically. So a person in a remote village, say, for example, in Uttar Pradesh, will not have the same options or access to the same kinds of hospitals or treatment versus a patient maybe living in Calcutta, where there are lots of options and lots of good cancer centers around.
Yeah. So, what do you exactly mean when we are talking about the advanced treatment? So, we know the three pillars of cancer treatment. So, what exactly is the research that is going on currently?
So if we talk about the three pillars separately, there's research in each of those pillars that is ongoing, and it will be ongoing forever because we're talking about oncology, ever evolving branch. So when I talk about radiotherapy, because that's what I've been particularly trained in, radiotherapy research mainly talks about, I think these days our main focus is organ preservation and how to selectively treat a cancer, minimizing the risk of toxicity to the other critical organs around the area that we want to treat. So say, for example, I want to treat the breast and for breast cancer. And we very commonly use radiotherapy as part of breast cancer management after the cancer has been removed by surgery. So treatment has now shifted from removing the whole breast to removing only the tumor, which is breast conservation surgery. And then that follows radiotherapy. Otherwise, the risk of recurrence is very high if you don't have the radiotherapy. So in the way that we give the radiotherapy, we want to basically, kind of spare the lungs and the spinal cord and the heart, which are all around the breast, just underlying the breast in the chest wall. So focus is now on developing techniques like motion management, because when we breathe, our chest is constantly moving, and the radiotherapy has the opportunity to hit other areas that we don't want to treat. So that kind of motion management techniques, or making radiotherapy very selective, maybe using radiotherapy to treat a very small area of cancer, sparing everything around, and trying and escalating the dose that we give to that very small area because we're not treating a very large area with a lot of margin. So that kind of research is very up and coming in the field of radiotherapy, trying to make it more conformal, which means more shaped in the shape of the target, sparing critical organs, and making it more precise, basically. So that kind of, and if I talk about systemic treatment, main focus now in research is to, like I said, targeting specific molecules, specific proteins, specific DNA changes or mutations by things called targeted treatment, monoclonal antibodies, tyrosine kinase inhibitor. So these are all biological terms, maybe difficult for laymen to understand, but what they mean is they basically target very selective things in the cell that is cancerous, and not have too many side effects on all other cells in the body. So research in oncology primarily deals with all of that nowadays.
Okay, so does the term precision oncology mean a broader umbrella term? Or is it a particular type of therapy, which is distinct from targeted therapy?
No, no. So it's an umbrella term. Precision oncology entails everything that I just spoke about. So it means targeted therapy. It means using immunotherapy, which is also precision oncology. It means using particular monoclonal antibodies to target a particular change in the cell that is cancerous, so that the development of cancer or the progression of cancer is limited and is stopped. So what these agents particularly do is, by targeting these factors that are leading to the cancer from progressing further and from those cells to keep dividing, they basically target cell division and stop cell division so that there's cell death in the end of the day. So a term medically, we call it apoptosis, which means cell death. So that kind of thing. So that's precision oncology. It also means precision radiotherapy, I would say. So it's not a particular kind of therapy that we offer to a particular patient. It's the kind of treatment that basically talks about how to make oncology treatment very selective. And the basic agenda of using precision oncology and to making oncology treatment as precise as possible is to reduce the number of side effects, because it is a well-known fact by now that cancer treatment has a lot of side effects, and more than the cancer affecting a patient, there are so many people just complaining about the side effects of treatment
Yes.
rather than the cancer itself. So the whole aim now, and it has always been that way, is to reduce those side effects so that quality of life is not impaired. And at the same time, we are able to cure cancer.
Yeah. Okay, so today I had a conversation with one of the survivors from Chennai.
Yeah,
He had a tumor, a malignant tumor at the back of his at the beginning of his spine and at the space
yeah,
of the medulla oblongata. So
yeah.
he said that it was detected in the first stage itself. So what happened is he went for the surgery first, and then he was advised for 12 rounds of chemo, and he got 6 rounds of chemo. And then he went for radiation therapy. So, and then he also mentioned that after around about 18 years of after his radiation therapy, he had this one thing where he, lost his hearing.
Oh,
So,
okay.
yeah, so he lost his hearing, and then he went through the necessary treatment. So,
Yeah,
he went for surgery first, so the tumor was removed. And
yeah.
then I want to know the significance of the chemotherapy and then the subsequent radiation therapy. Like, what were their roles in his treatment process?
So when you have a cancer, you want to remove it as soon as possible. There's the only way to remove it is by surgical resection. So your patient had that. And then the next thing about oncology treatment is to try and reduce the risk of recurrence, because we know that cancer will recur, and the higher the grade, the poorer the prognostic factors. So the worse the kind, we know that it is definitely going to recur in 5 years or 10 years. So our aim as oncologists is to find more and more treatment so that this risk is reduced. So what chemotherapy does in the adjuvant setting. So when I say adjuvant, I mean something that comes after the main treatment, which is the surgery in this case, is to reduce the chance of micrometastasis. So metastasis means spread to distant organs of the body from the local, like the primary organ of origin. Micrometastasis means, you know what micro means. Micro is something that we can't see with the naked eye. So micromets means that the pathologist, even if we collect cells from the patient's body, the pathologist will never be able to process those under the microscope and tell us that, yes, this cell, which is probably distant from the primary organ, has cancer, because it's a micromet. It can't be seen with the naked eye or under the microscope. It's difficult. So because we want to reduce the chance of micromets from developing, which means these microscopic cells are now they have the ability to spread, because that's what cancer is. It spreads via the lymph nodes, via the bloodstream. We want to reduce the chance of these micromets from, even if they are present in a person's body, we want to minimize the chance of these micromets from spreading. And that is where the role of systemic treatment comes in, be it chemotherapy or immunotherapy. It basically, these drugs, especially chemotherapy, because you asked particularly about it. So these are just groups of pharmacological drugs that, like I said, target cell division, lead to apoptosis, cell death, lead to some DNA changes, mutations, so that the ability of these cells to grow in an uncontrolled fashion, which is what cancer is inhibited. And that's how chemotherapy works, by killing these micrometastatic cells and all the changes within them, so that these micrometastatic cells can no longer grow and not lead to a macromet, which is something that we will ultimately see as a recurrence. So basically what it's doing is reducing the chance of recurrence. Radiotherapy is again a very local treatment. So like systemic treatment, chemotherapy, it's going to act on the whole of one's body, because it's a drug that someone's having either orally or intravenously. So it's going to act on the whole of the body, and wherever micrometastatic cells may be, there is a chance of controlling those cells. Radiotherapy won't act that way, because radiotherapy you'll only be giving to a particular place, which is basically the place that has been operated. So the post-operative bed with a margin is what we treat with some additional radiotherapy after the patient has had the main treatment, which is the surgery. And that is just to sterilize that area. So just in case some micrometastatic cells have been left behind in that tumor bed, which is where it is most likely to be left behind, which is where the surgeon went in and operated. We basically just go in with some extra treatment, local treatment, which is kind of ablative treatment, we call it, which means killing. That's all that ablation means. So that's how the high dose of X-rays that we use, the radiotherapy, kind of sterilizes that post-operative bed. We use a margin so that we've covered enough area and we know for sure that there's no micrometastatic cells left behind in that area. So that again, there is more chance of local control. So local control is what we achieve with extra radiotherapy, sterilizing the post-operative bed, and systemic control. So control over the whole of the body so that there is lesser chance of metastasis, lesser chance of distant spread and recurrence is minimized by chemotherapy.
Okay, so what I understood from this, so basically, I talked to a lot of people earlier, and they said that after like the process of having the chemotherapy is very painful. Right, so it's like they shared their experience, and they almost cried. So
Yeah.
so why do people still go for chemotherapy? Like I know a lot of people who go for chemotherapy as their first option. So I understand that surgery cannot be the first option always, because there are regions where which cannot be operated as safely as others. But then
Yeah.
again, why do people prefer chemotherapy even after the side effects which it causes?
So it's not about preferring chemotherapy. Chemotherapy doesn't have curative role, first of all. And uh, I would say if you ask me what the most overhyped treatment is amongst all the treatments that we know in cancer treatment, among all the options, I would say chemotherapy is the most hyped because it is not curative. It
Yeah.
won't take away the cancer. The cancer is still going to stay. It is probably just going to kill a few cancer cells, maybe reduce the volume of the disease, maybe reduce the burden of the disease, and kind of downstage or downsize the tumor that we can see. But it's never going to eliminate it. So you're not cutting something out with chemotherapy. You're just reducing it in size, killing a few cells, that's all. And that just means that you're controlling it, but not curing it.
Okay.
So one I mean, I don't exactly know what you mean when you say one prefers chemotherapy, but that's not what is going to be offered to a patient if the patient has a curative cancer, is what I would say. The treatment option that we usually offer to curable cancers is either a surgery or a radiotherapy, or a surgery followed by chemotherapy plus minus radiotherapy and things like that. But never chemotherapy alone, because chemotherapy alone hardly has any curative role in any place. So either we use it before the main treatment, which is the surgery or the radiotherapy, to reduce the size of the tumor so that it's more amenable for surgery and radiotherapy, or we use it in the adjuvant setting, like I said, after we've done the mainstay to reduce the risk of systemic spread. Or we use it in incurable metastatic disease who present with a lot of symptoms from the cancer. And there's no other way of curing it basically because it's all over the body. That's when we offer, very commonly, that's when we offer first line treatment with chemotherapy, because we basically want to achieve systemic control. So
Okay.
patients have chemotherapy in these settings. They don't really have only chemotherapy as cure of their cancer. If someone has only chemotherapy, then probably we're talking about a cancer that's not curable.
Okay.
That's the reason why they're only having chemotherapy and nothing else. But yes, I mean, it does come with a lot of side effects, which is why there has been a paradigm shift where we're now looking at other options of systemic control, like immunotherapy, targeted treatment, the ones that we were speaking about, because these selectively target these cancer cells, sparing all the normal cells, so that there are less side effects in the end of the day.
So what are the recent research breakthroughs that people should actually pay attention to?
I think, again, radiotherapy, if I talk about radiotherapy, there is something called stereotactic radiotherapy. So it's called SABR or SBRT. So basically stereotactic body radiotherapy or stereotactic ablative radiotherapy. So what it does is when there's a cancer, it's a local cancer. Say, for example, let's talk about prostate cancer. It's a local prostate cancer that a patient has. And unfortunately, it's spread to a nearby bone, because most commonly prostate cancer spreads to the bones of the vertebral column or the pelvic bones, the hip bones. Say, for example, this patient's got a prostate cancer with a tiny metastatic deposit in one of the lumbar bones. So the tailbone, that kind of area, the sacral, lumbosacral area. So it's a very tiny area of disease, but unfortunately, it's a metastasis because that's not where the cancer originated. It's the prostate that it came from. So it is distant spread, but it's a very small area that is still curable. So that situation is, we call it oligometastasis. Oligo is small, small number, small volume, and metastasis, you know what it is. So oligometastatic disease is very easily treatable or curable nowadays with something called SBRT, stereotactic body radiotherapy, which means precisely targeting that lumbosacral met, adding a very, very tiny margin around it because there's hardly any disease around it, we know, and then treating it to a very, very high dose of radiation. So dose escalating in that very small area without adding a big margin so that we are not covering a huge area and giving a lot of side effects to that area, but still treating it with some curative treatment, which is the radiotherapy, which has the potential of removing or eradicating or ablating the cancer. Versus in previous days, before we discovered something called SBRT, before we knew that oligometastatic disease could still be curable, although it was metastatic, but early metastatic. In earlier days, what used to happen is we used to term this very generalized, in a very generalized way as metastatic disease. And then the patient would just have hormones and systemic treatments, not curative treatment. He would not have surgery. He would not have radiotherapy because doctors would tell the patient that, we're sorry, your disease has now spread elsewhere, which means it's metastatic. And obviously, that's not curable cancer. So you're going to die of cancer at the end of the day. But that doesn't happen now because of these precise ways of treating with radiotherapy. So this patient can still have surgery for the prostate and have very selective, precise radiotherapy for that oligomet and basically be cured. So that is basically very recent, I won't say very, but developed form of advanced radiotherapy, precise radiotherapy called stereotactic radiotherapy, say in the last 15, 20 years, which most people are not aware of still. Cancer patients are because they do hear of these treatment options, but laymen who don't have cancer, they usually are not aware. But these are very big breakthroughs, especially in clinical oncology, in radiotherapy,
Okay.
I would say.
So when, for example, a person hears about the term new treatments or breakthroughs in cancer treatment, so what should they realistically expect? Is it, as far as I understood from this conversation, I think they should expect like to manage the cancer better, also to improve their lifestyle after the treatment is over with dealing with side effects instead of the actual curing of cancer, like specifically. Is it true or?
So new treatment, do you mean newly discovered treatment? Or
Yeah,
just new treatment for the patient, as in a new line of treatment
a new line
that the
of,
patients not have?
yeah,
So something that the patient has not had before,
yes,
that kind of new.
yes,
So if a patient is on treatment and if the cancer is still progressing, if there's no response, then obviously you stop that line of management and you switch to a second line if the patient's still fit to tolerate that second line of treatment. So say, for example, breast cancer, a patient has breast cancer, the patient has had primary surgery, radiotherapy, chemotherapy, everything that she needed. And then she's been on remission, which means the cancer is cured. She's cancer-free. She's having hormones because her breast cancer was hormone positive. And so we recommend hormones for at least 5 years from the diagnosis. So she's having hormones, she's okay. And then 4th year on hormones, we suddenly see that she's progressed. Her cancer has, it's come back. So it's recurred, and she now has metastatic disease, which means that there's bone mets, there's liver mets, lung mets, and stuff like that. So lots of distant spread. So we know that the hormones are not working. So now the oncologist is going to recommend a new form of treatment for her, which is going to be second line for her. So when a patient is offered second line of treatment, it actually is good news because the patient knows that I am fit and my oncologist actually feels that I will be able to tolerate this treatment. Otherwise, I would not have been offered anything. And my oncologist would have just told me that, I'm sorry, the treatment's not working for you. You're not fit enough. I don't think you'll be able to manage anything, the side effects of the other treatment options that I have. So I'm not going to offer anything to you because I feel that the risks are more than the benefits of this. So we're just going to support your symptoms. We're just going to manage your symptoms, try and make you as comfortable as possible, and not really treat the cancer. That is bad news, which means that you're basically moving towards the end of your life. uh, you don't have any more oncological options left. So your cancer will remain and it is going to grow because it will not be cured, it will not be treated. But if someone is actually offered new lines of treatment, second, third lines of treatment, it is good news because the doctor knows that the patient is fit. And although the cancer is progressing, overall, the patient's performance status is good enough to offer more treatment, because oncological treatment is basically going to bring about more side effects. So the doctor feels that my patient is going to tolerate the side effects well, which is why I'm now going to give another chance and support with another line of management and see how the cancer responds to that. So you if a patient is offered new treatment, it's good, and you expect response basically because your cancer is not responded to the previous line. You can expect response this time because you're moving to another form of treatment, another drug or another therapy.
Okay. What do you think? What do you think cancer treatment will look like 10 to 20 years from now? Given the pace of the research which is going on, or globally, where do you think it will stand after, a decade or 2 decades?
So there's a lot of research going on around de-escalation of treatment. So earlier, the cancer is detected, and better the cancer is I mean, no cancer is really good, but comparatively, if you look at some tumor characteristics and patient characteristics and molecular characteristics and things like that, we are able to assess risk and we are able to prognosticate, which means we know how the cancer is going to behave with or without treatment. So there are some cancers that are good cancers to have, that you will have if you're lucky. And if these cancers are detected very early, sometimes we de-escalate treatment, which means that in the earlier days, or if now a patient is offered with complete radical treatments of surgery followed by radiotherapy, chemotherapy, and everything like that, which would have been very generalized, we are now looking at de-escalating treatment, which means maybe we take away some treatments and still see that overall survival or recurrence-free survival is hardly making any difference, which means that why give unnecessary side effects to a patient when he or she doesn't need it, in terms of cancer outcome, in terms of survival. So there's a lot of work going on around this, and de-escalation. I mean, although there's debate, so not every oncologist, not there's no unanimous decision or agreement as to yes, we should de-escalate. There are lots of oncologists against it as well, because no one wants to take a chance at the end of the day. If your patient is fit, then you want them to have as much treatment as possible, because you want to use everything in your armamentarium to eliminate the cancer and prevent it from coming back. But there is a change in practice nowadays. Some oncologists in some parts of the world are looking at options of de-escalation, because to them, quality of life is more important. So in 10 to 20 years time, I would expect a few more, de-escalation options to come around, and also a lot more personalized treatment and precision oncology to be implemented in real world practice.
Okay. Do you believe that, what do you think is the role of AI in the treatment process? Do you believe that it plays a significant role or that it would outperform doctors? Last day I was going somewhere and I saw this one poster. Now all the major hospitals in Kolkata are creating another separate cancer institute branch. So
Yeah.
I was seeing a poster, it was written, robotic surgery in cancer treatment. So do you
Yeah.
that robots can outperform doctors? And like, what is your take on this?
So robotic surgery is not entirely AI. The surgeon is still operating the robot that
Yeah.
is actually operating the patient. So robotic surgery is not an example of AI, if you ask me. Um, Although AI is, I think nowadays, I'm not a surgeon myself, so these are all things that I've read about or heard from my surgery colleagues. I think nowadays there is role of AI in kind of suturing things up after you're done with the surgery, when you're trying to suture back the layers of skin and organs. That's when you probably still, because that's an automated technique, right? So it's a repetitive technique when you suture things back. So once the mainstay of the surgery is done and it's all about finishing it off by bringing back layers and joining back layers, That is, I think, the only place where there is still some studies on using AI and things like that. But overall, robotic surgery is nothing that does not require a surgeon or a doctor. It completely requires a surgeon to be using those robotic arms. I think there's a model that they use called the Da Vinci robotic
Yeah.
model. They use it for prostate cancer very commonly. So because prostate cancer has had huge evolution than it in terms of robotic surgery, and most of the prostatectomies, removal of prostate gland for cancer, is done by robotic surgery. That's what's done in our institute here in the UK as well. And there are centers in India that practice robotic assisted radical prostatectomies. And that's entirely a place where the surgeon is sitting on a console with a lot of machines and gadgets and buttons and things like that. So very high tech. And there are robotic arms that he is controlling or she is controlling. And he or she is just able to see what's inside because there are cameras fitted in the head of the robotic arms. And that's going inside the person's body. And the surgeon is able to see what is there in the inside. And it's basically kind of using those robotic arms to pinch out things, cut out things, and then suture them back. So there's a very, very limited role of AI there. If you ask me, role of AI in oncology in general, I would say there's a lot of work going on the role of AI in data management and in treatment planning, in the sense that there's something called a multidisciplinary team meet, MDT, before a patient is actually treated or a plan is discussed. Everyone comes together. So surgeons, oncologists, pathologists, radiologists, everyone comes together. And there's a multidisciplinary team meet as to what is going to be the best treatment plan for this patient. So every patient is discussed in this MDT meeting, after which they are seen, but individually in clinics. So these MDT discussions require all radiological images, so all CT scans, MRI scans, PET CT scans, and all histopathology reports. So any biopsy or cytology that has been done, we need reports to be discussed by the pathologist and confirm the diagnosis, confirm the extent and the stage of the cancer before we can actually recommend a treatment plan. So this requires a lot of admin work, which means that there's someone sitting, in the background trying to acquire these images, these reports, etc. So that once all the doctors come in for the MDT discussion, it's a very smooth flow of cases where someone or a group of people have to come together and then draw all those reports and images of scans so that the doctors can then come in and then review all of that to generate a good treatment plan for that particular patient. So there is some studies, some companies that are now trying to use AI. Although there's a lot of validation that's required, because you can't just randomly wake up one day,
Yeah.
use AI and say that, yeah, all my reports are absolutely perfect and we should base all our decisions on this now. So there's a lot of validation that's required. That takes years. And then once that's established, then hopefully one day we're there, AI will probably play a very important role in at least the MDT management and how we extract all those information on the results, so that our MDTs are, very quick and smooth flowing, so that we can cover lots and lots of patients within a very small amount of time. And ultimately, how that helps is it improves um, the speed of treatment delivery, because plans are made quickly, and maybe in a particular MDT spanning for 2 hours, you're able to discuss 100 to 150 patients. So all those 100 patients have a treatment plan generated in a span of just 2 hours, because we are now using AI to generate all their information, to derive all their information
Yeah.
at a go.
Okay.
But that doesn't mean that AI is going to overpower doctors or oncologists in any way, because AI will not be able to treat cancer,
Exactly.
unfortunately. So, yeah.
Yeah. Is there anything that concerns you about the cancer research which is going on? And is there something which excites you the most?
Yeah. So, like I said, I talked about de-escalation. That is, kind of concerning in some aspects, because like I said, so because I'm a middle grade oncologist, I'm still not a consultant, so I don't entirely take decisions for my patients. Now that I'm working in the UK, so I'm working under or with oncologists, and so I see them taking decisions or support them, help them in that decision making, but not entirely taking decisions myself. But I've seen this, concern in a group of oncology um, consultants who are not very happy with de-escalating treatment, like I said. So that's kind of a concern because there's lots of work going on
Yeah.
in kind of preserving organ and
Yeah. Best
de-escalating treatment and
practice
things
to,
like that.
uh,
Yeah, so because the whole point of preserving an organ with cancer is to improve quality of life and improve cosmesis more than anything else. So, for example, now we live in a time when we are treating bladder cancer with radiotherapy very commonly. Earlier, bladder cancer meant removing the bladder. And then what happens after you remove the bladder? You end up having something called a neobladder, which is a new bladder, and it's basically kind of a tube through which you're urinating. So that's not a good thing to have lifelong. You're cured of cancer because it's been removed, but unfortunately, you end up having this tube and this artificial bladder that you're using, and it's not good to have. And it's kind of a social stigma. You're not comfortable in then going out and mingling with friends and family because you're kind of embarrassed because of this new thing in your body that nobody else has. So that's why we shifted our practice to kind of preserving the organ, preserving the bladder, and treating the cancer with radiotherapy instead of the surgery. But then the risk of the cancer coming back still remains because someone is still, that person still has the bladder. So there, obviously, we do this now because surgery and radiotherapy have shown to have equal outcomes, which is why the standard of practice is now to offer to the patient what the patient wants after kind of downsizing or um, yeah, I would say downsizing the tumor with some chemotherapy. The patient is then brought back to clinic and then asked, what do you want? So
yeah,
these are the pros and cons of each treatment option. What do you want? Whatever you want, we will do. Because the treatment outcome ultimately is going to be the same. Cancer outcome evidence shows that in case of bladder, and that's the reason why we offer radiotherapy. We wouldn't be offering to preserve an organ if we knew that the risk of cancer coming back is higher with that. So in bladder, it has been established that the risk of the cancer coming back is equal if you remove versus if you don't remove and treat with radiotherapy, which is why that is an option. But that's just for bladder. If we talk about other organs, I mean, there's still a lot of work in trying to preserve organs like the rectum, for example. There's lots of new data coming up about kind of going in with chemotherapy, radiotherapy, everything else, but not surgery to remove the rectum if someone has rectal cancer. And then anal cancer is also treated with chemoradiotherapy and not surgery. So the reason why we're doing all this is because we want to preserve function as much as possible after treating the cancer. But it's not always the way to go because you still end up giving a risk of the cancer coming back. Sometimes it's acceptable if the patient's very young and fit. The patient rather chooses to, have that organ and that function
yeah,
and a normal life,
yeah,
and instead of worry for that particular day when the cancer comes back. So it's about weighing all these risks
sure.
and benefits and
Yeah,
personalizing treatment and basically tailoring treatment around the person sitting in front of you, the patient that you're treating. So one size doesn't fit all, like I said. So these are like areas of, I wouldn't say concern, but areas that really, really need a lot of focused research and definite data suggesting which needs to be done when,
mhm,
whether to de-escalate, whether to preserve or not, because we don't want to do harm to a patient in the name of doing
yeah,
good.
yeah. So, as I had talked to you earlier as well, you have experience with both the Indian dynamics and the UK dynamics. So,
Yeah,
do you believe that there are any real differences between cancer care, like not just the treatment options? Because I think that India, yeah, in the next 10 to 20 years will be able to experience all the advanced treatments we talked about right now, and the research which is ongoing.
yeah,
But in terms of the patient outcomes or the financial
yeah,
breakdown, the diagnostic process as a whole,
yeah.
do you think there are any real differences in all these sectors?
Yes, I think if I need to point out, then I would say screening needs to be more stringent, as in routine regular mandatory screening needs to be implemented much more strictly and in a much more, I would say, at the government level, and not just spread awareness and do public awareness events to ask people to come forth with their initiative of getting oneself screened. So that needs to change, and the government needs to step in and say that if you're 30, you need to come in for cervical cancer screening or
Yes.
breast cancer screening and things like that. So if you're 50, you need to come in for breast cancer screening. If you're 50 or 70 or 60, a man smoker, you need to come in for colorectal screening. And the government needs to actually get people to come in for screening instead of just spreading awareness and expecting someone to
Exactly.
randomly pop
Yeah.
into clinic one day. So screening programs need to be implemented in a much more stringent fashion is the first thing to do. And secondly, I think the main difference that I've seen in the UK in cancer care. So I would say in terms of treatment options and all the advancements that we see and everything that we are doing to improve cancer outcomes is equal in India as well as the rest of the world. Especially, I mean, the UK where I am now. But the main difference that I see is the treatment support that patients receive when they're treated here versus the patients that are treated in India. Because here in the NHS, they have very intelligently included lots and lots of allied health professionals in the cancer team, which means that there is a specific dedicated clinical nurse specialist for a particular type of cancer. So,
Oh,
say, for example, I am a breast cancer patient. I don't just have an oncologist to talk to about everything that is going on in my life. I also have a clinical nurse specialist who is dedicated for breast, who specializes in breast, and who only sees breast cancer patients from the nurse point of view. So that person is basically my common link between my surgeon, my clinical oncologist, my medical oncologist, because not one doctor is treating you at the end of the day. There are so many doctors that are involved in your care, and each of them have played a part in the various stages of your treatment. So when I have a doubt and when I have a query, when I feel like the cancer is coming back, say for example, there is someone I need to talk to, but I am confused. Do I talk to the surgeon? Do I talk to the oncologist? What do I do? And it also increases the burden of these doctors because they can't, like, they don't have the capacity, uh, I would say, to to pick up recurrences and things like that in clinics. Um, so this is a person that I can call and then let them know this is what I'm feeling, this is my symptom. So where can I come? What should I do? So the clinical nurse specialist is trained to give you advice and to show you the right direction of movement and communication whenever you have any doubts or concerns. There's also specialized cancer psychology team, and then de-addiction team. So for smokers, or for alcoholics, there's de-addiction teams that specialize in cancer patients, that know how to communicate with cancer patients who are extremely addicted to substance, which is probably leading to the cancer or making it worse. Because we know that while a patient is being treated with radiotherapy, chemoradiotherapy, and the patient still continuing to smoke or drink, outcomes are poor. You'll end up having more side effects, and what we want to achieve with the radiotherapy, we won't achieve. So
mhm.
it's a lose-lose situation.
Yeah.
So de-addiction is important, and there are specific teams dealing with that. So the oncologist will not have to give a lot of time in counseling about de-addiction in the middle of a busy clinic where the oncologist needs to see other patients and treat them. So that kind of system is still lacking, I would say, in India, because a lot depends on the clinical doctor. And there are less of allied health professionals supporting the doctor in treating. And this support is, I would say, 50% of the treatment at the end of the day. The treatment outcome essentially depends on what treatment plan you're on and also what support you receive while you're on the treatment, which India needs. Um, yeah, and I think these are the two main differences that I've seen. And obviously, I talked about the financial situation where NHS is a big help whenever you're in need. And there is something called a 2-week wait pathway for
Okay.
cancer, which means that if you have a cancer symptom, if your GP, your general practitioner doctor, is concerned that you may be having cancer because you have a red alarming symptom, the GP is going to put you on a 2-week wait pathway. And then all the investigations that are required to diagnose this cancer are going to happen mandatorily within those 2 weeks. If there's a breach, it's big news. So that can't happen.
Okay.
So, there will be action taken against a
Okay.
person who's breaching that constantly. So, so everyone talks about, we are nearing breach, we are nearing breach. We don't want to do that. So that's a red sign. And there are very tight timelines and pathways that the NHS has put into place, which again, India needs, because if there's a lot of the cases that I used to see when I was training there were because of late diagnosis and people didn't come up in time. Nobody was there to guide them. They didn't have any GP, because that's not how our system works. Not everyone is assigned a regular GP that will take care of them. So, which is why there was, delay in diagnosis, and ultimately we didn't achieve what we were meant to if the patient had come a lot earlier.
Okay. So coming to the final section of our conversation, what do you think is something that everyone should know about cancer that they often do not? I'm not talking about specifically patients, because I feel like the cancer patients often know a bit more about the treatments and the new technologies which are coming up as compared to the normal people who often just label cancer as a fatal disease, and that they cause unnecessary fear among people, I would say. So what is something that you think everyone should know but they do not?
I think everyone should know that cancer is treatable and entirely curable if it's reported early. So if you have a very localized early stage cancer, then there is a high chance that you will be cancer free after receiving appropriate treatment. The treatment can be extensive, it can be radical, it can have side effects, it can be difficult to tolerate, but once you're done with it, you will be cancer free, which is good news, which we didn't know till maybe 30, 40 years back. We would have this idea that, I mean, if I have cancer, I'm going to die in two days' time. So that people need to know. People do know a lot more than they used to. But obviously, in our country, because we have, there's a major chunk of the population that's still underprivileged, that's still below poverty line, that's still below education standards. So we haven't really been able to inculcate awareness and knowledge among every part of the society, of the Indian society. So there are people that still don't know this. So we need to work more and more. I know we are almost there, but we need to
Work harder.
continue to work. Work harder, continue to do what we're doing, so that more and more people are aware that they need to report in time. The moment you see something abnormal, the moment you see something that is not regular for you, and you're concerned, go to your doctor. Just don't waste time. Go to your nearest doctor, GP, whatever, whoever you trust. Go and report to them so that they can and ask questions. I mean, more than leaving things on people and just assuming that I'm absolutely fine. There's nothing wrong with me, and then having that weird faith in God that, I
Yes.
mean, nothing can happen to me, and I will always be cancer free and all evil free. Don't assume things like that. It is rapidly increasing in incidence, the disease, cancer, and it's very, very common now. So I would say report early. The moment you see abnormality, report to your GP, report to your doctor, get yourself tested. And the other thing is, once you're on treatment, and I've seen lots and lots of cancer patients in India who think that cancer is cured by starving cancer cells. And that's a very, very common idea, especially among the underprivileged people that I used to see in the government hospitals where I was training. And they used to starve themselves, not eat a proper regular diet, low on proteins, carbohydrates, thinking that cancer depends on the sugar levels in my body. So if I starve myself, if I take less sugars, then they're going to die and then I'm going to survive. That's absolutely not how things work. So they should be having, in fact, more and more nutritious diet and a high protein diet, lots of fluids. So eat and drink well while you're on treatment. Otherwise, if you fall weak and low on nutrition and hydration, then you won't be able to tolerate treatment and we'll have
Yes.
to stop. And that will kill you rather than,
Yeah.
starving your cancer.
Yeah. What is one biggest mistake that patients often make? Like apart from whatever we talked about right now, what is one thing which
Yeah.
you saw that the patients make a mistake, and what is one thing that could save them today? More of a
I think I would
general
say,
advice.
yeah, I would say the same. I would say the
Yeah.
same. Reporting in time could save them,
Yeah.
and eating and drinking well while on treatment would save them and would make them tolerate treatment much, much more than otherwise. Um, Also, follow-up is important. So some patients, once they are cancer-free and once they've just finished their treatment and there's been one scan to say that you don't have any cells, any tumors, anything anymore, and you're free of cancer, they think that it's not going to come back. I am cancer-free. I don't need to go back and see the same oncologist anymore. I'm done with this. And it's true. You feel you're done with it because there's a lot that you've gone through. There
Yeah.
are lots of side effects that obviously the people treating you did not have to go through. It was you that was going through. So everyone appreciates that. But when we say that a person needs 5 years of follow-up and 6 monthly or 3 monthly clinical examination and a CT scan or a PET CT scan or a camera test to see whether the cancer is coming back, it means something. It
Yeah.
means that there is evidence, robust data um, in the background to tell us that if we do not do this, and this is standard of care, then there is a higher risk of the cancer coming back because you're not detecting it in time. And then the patient will ultimately come back with a lot of symptoms from a metastatic disease, and it will be incurable at that point, and you lose your patient before time. So that is a big mistake that people do. Once they are cancer free, they think that they don't need follow-up, but that's not true. There is a minimum time of follow-up that every patient needs after being treated and becoming cancer free.
Okay. So as you mentioned previously, people need to report themselves whenever they feel something abnormal going inside their body. So
Yeah.
what in your opinion makes people act early? Like not just awareness, but what is one thing that you think people make people act early?
I would say if, like I said, screening, if it was made compulsory and if it was coming from the government level and the policymaker level, rather than leaving it on me to come into clinic and get myself screened, I would say that would obviously make people act early because you're being asked to do that, you're forced to do that. So, and that's how these systems here work, because now that I'm here, the moment I came to the UK and I signed up with a particular GP around the area that I live in, I kept getting messages every fortnight because I am 30. They keep sending me messages to say you need to come for cervical cancer screening. You're overdue with your cervical cancer screening. You're in that age group that is at risk, so you need to come in. So even if I forget, they won't let me forget.
Yes.
And every fortnight, they will remind me that you're in that age group, you're high risk. You are in that bracket of people that the NHS recommends cervical screening for. So you need to come in. And then when I did not respond to those messages, someone called me from my GP center and said, we haven't received a response from you. So, dude, what's going on? You need to come in. So that kind of pressure and that kind of
Yes. The
implementation.
system needs to be
um,
strong.
Yes, exactly. I know it's difficult with our kind of population because it's huge,
Yes.
and we are not the UK, we are India, and diverse country, lots of population, lots of areas to seep into. Communication is not great in every region, and because I live in London. This is just a GP surgery in London that I'm talking about, and here, even if I'm going to the remotest of villages in the UK, things will hardly be different from London. But I know that's not the case in India. So there's huge differences between regions
That
as well. So it's difficult to implement, but we should be starting to looking at maybe doing it at least for the cities or the immediate peripheries of the cities if that's easier, and then gradually moving towards the villages and very remote areas as well, so that we kind of, in fact, actually I'm wrong in saying that because the remote areas need this more
yeah.
rather than the city people because they are kind of aware, but the target population should be the reverse actually. So we need to figure out ways, government needs to figure out ways, we need to build policies so that this kind of thing happens where people are calling and messaging and forcing you to come for a screening so that you act and so that things are detected in time and then things are obviously cured in time.
Okay. So finally concluding this entire, it was great talking to you, by the way. After
My
having
pleasure.
this entire conversation, what would be your message to the entire audience watching this? What would be one message you would want to give out?
I would say cancer is curable now. There are lots and lots of treatment options available, lots of research, lots of advancement, and still ongoing. Um, report in time. Um Anything abnormal that you see, anything that you are suspicious about, anything that you're concerned about, uh, it doesn't have to be a very big thing. It can be a tiny thing, like maybe having regular headaches and you think it's migraine. You think it's, you sitting in front of a laptop or a computer all day leading to headaches. It might not be. It might be brain cancer. So you don't know that. Nobody knows that unless you go and get a scan done or report to a doctor to get things started. So anything fishy, anything abnormal, report to a medical professional. And once you're on treatment, don't worry about the side effects. There are lots of supportive treatment that is available now to treat those side effects. Don't, stop taking a drug or stop taking therapy just because there's a bit of side effect that's happening and you anticipate that you can't handle if it goes on. Don't do that. Always, consult your oncologist and speak about these problems so that they can then support you with other drugs and other medications to take care of these side effects. Because what we don't want to do is break in treatment, because that basically worsens outcomes. So once treatment starts and then we break it, that's not good. So that's just giving the cancerous cells more opportunity to grow, actually. And there's a lot of biology behind that. So don't do that. Always consult your oncologist to, for advice as to how to manage these side effects and things like that. And there's a lot of hope in oncology now, which is great. There are lots of oncologists, first of all. So training in oncology has improved significantly in our country as well as internationally. Very, very booming subject, very, very booming branch for doctors. And there is lots and lots of hope because there are lots of oncologists now. So, and your oncologist is always your best friend at the end of the day, because that's a relationship you don't forget easily, because
Yeah,
you're very dependent on them.
yeah.
So trust them. What they're saying is based on data, and always do your own research. But at the end of the day, you choose what you want. No one's going to force you for treatment. But do your research, but also try building that trust on the oncologist that's seeing you, because that plays a huge role in outcomes as well, that trust and that friendship with your doctor.
Okay, so thank you so much for sharing, for giving us this opportunity to be able to have this conversation with you in this platform. And it is an honor to have this opportunity and for such an insightful conversation. Thank you so much, not just for your expertise, but your perspective as well. It was
Thank
a
you for
pleasure.
having me. It was great talking to you.
Thank you so much. It was a great experience overall. And I hope that people actually impact from this conversation.
Yeah, yeah.
That is most important thing.